Rupa, now it has come.
Thank you, sir.
Rupa, we can start now.
Sir, 1 more minute. We'll wait for 1 minute, sir.
Okay, ma.
Yes, sir. Shilpa ma'am, so many are waiting in the waiting room. Even the speakers are asking. Okay. Sir, we shall wait for 1 or 2 minutes. Most of them are waiting, sir. They're joining in the Zoom, sir.
Rupa, Balagopal sir, Murli, and Ramya Raghu madam, Srinidhi sir also came, ma. We can start, ma.
Okay, sir. Yes, sir. Good afternoon, one and all. I, Dr. Rupa Devi Garlapati, Professor from the Department of Conservative Dentistry and Endodontics, Sibar Institute of Dental Sciences, Guntur, with pride, enthusiasm, and excitement, welcome you all on behalf of the organizing committee to the final touch with experts, a virtual glimpse for final year postgraduates. It is with immense pleasure that we from the Department of Conservative Dentistry and Endodontics, under the able guidance of our Dean, Dr. L. Krishna Prasad Sir, hosting a virtual program, Final Touch with Experts 2 for the exam appearing postgraduate students from 3rd February to 26th February. We request our beloved Dean, Dr. L. Krishna Prasad Sir, to address the gathering. We welcome you, sir.
Hello, good afternoon, everyone, my dear friends and colleagues, senior faculty members, all specialist endodontists throughout India. I welcome all of you for this second series of Final Touch with Experts. After a successful completion of the first series of this program, our Department of Conservative Dentistry and Endodontics have felt that is really useful after the good feedback from all the participants last year, we thought we should continue this program. And at the same time, I welcome all of you also for this very good and useful program, especially for the final year exam going postgraduates. And on behalf of Sibar Institute, I thank all the faculty who are the guest speakers and accepting our invitation without any, help or advantage or any financial benefit for all of them. They have voluntarily accepted our invitation to be the part of this program. I welcome all the senior faculty members, Dr. Balagopal sir, Ramya madam, and all of the senior faculties and deans of the program, and all the faculty and postgraduates who are taking part actively in this program. And again, I congratulate the whole team of our Sibar Institute of Dental Sciences from the Department of Conservative Dentistry, Dr. Sunil and Dr. Rupa, who have coordinated this program under the guidance of Dr. Sayesh, head of the department, Dr. Nagesh, vice dean of our institution, for conducting this program. And hopefully all of you will, with the next 10 thing, there will be 10 series of 10 or 12 programs, continuous programs up there. And I hope all of you will get a good benefit out of this program and wish the program a grand success. Thank you.
Thank you so much, sir, for your advice, encouragement, and able guidance. Now, I request our Vice Dean, sir, Dr. Nagesh Bola, sir, to share his vision and thought process about the program. We welcome you, sir.
Hi. Thank you, Dean sir, for your constant support and help for smooth conduction of this program. Dear friends and colleagues, thank you one and all for utilizing the experience and knowledge of our expertise, teachers, and I thank all the speakers of their unconditional support and help. We hope by the end of this program, postgraduate students gain knowledge and be prepared for their exams. Thank you one and all. Thank you.
Thank you, sir. We are very much thankful to our guest speakers for their unconditional acceptance of our invitation to enrich exam-going postgraduate students with their immense knowledge, clinical expertise, and share their experience. Thanks to all the guest speakers for joining the virtual inauguration. Sir, shall we proceed, sir?
Thank you all the speakers. We will proceed for the first lecture. Thank you one and all.
I would like to announce few instructions to the participants before starting today's session. All the participants are kindly requested to turn off your audio and video during the presentation. Kindly post your queries or issues regarding the presentation in the chat box. Registered participants who are present throughout the presentation will receive the certificate of attendance. And at the end of the presentation, all the registered participants, please fill the feedback form to receive the certificate of attendance. We feel privileged to introduce our guest speaker for today's session, Dr. V.B. Srinidhi sir. Srinidhi sir has 14 years of academic experience. Sir has pursued his BDS from JSS Dental College, Mysore in 2005 and MDS from SGM College of Dental Sciences in 2009. Currently, Srinidhi sir is working as professor in St. Joseph Dental College and in charge for the Nanoscience and Oral Microbiology Research Center in the same institute. Sir was awarded research grant from IACD in the year 2017. Sir was a scientific co-convener for the 33rd IACD National Conference hosted in Vijayawada in the year 2018 and was the scientific chairman for 22nd IACD National PG Convention, Rajahmundry in 2022. Sir was a keynote speaker for various CDE programs conducted at the university level. Sir designed few scientific models like fluid filtration, saliva sterilizer, intrapulpal pressure simulation model, composite preheater, thermocycler, microbubble generator, laminar airflow, anaerobic chamber, and sir also applied for patent for Gutta Percha sterilization equipment. Srinidhi sir has key interest in photodynamic therapy in root canal disinfection, silver nanoparticles, and biomimetic remodulation of hybrid layer. We welcome you, Srinidhi sir. We request you to kindly proceed with your presentation on endodontic diagnosis.
Thank you, Rupa. That was a wonderful introduction of mine. Good afternoon, everyone. So, without wasting much time, let me start with the presentation. So, is the screen visible? Is my PPT visible to everyone?
Yes, sir. Yes, sir.
Okay. My voice is clear?
Yes, sir. It's clear, sir.
Loud and clear, sir.
Yeah, then we'll start. Okay. So, it's a lengthy topic. Yeah, I try to cover and, we'll try to explain how much ever is possible with the time allotted. So, end-on diagnosis is the main pillar in our clinical practice. So, through which we can actually diagnose few cases as the treatment modality is also different. So, it's a determination of a nature of a disease made from the study of signs and symptoms. And when we want to diagnose, we need to collect all the possible information, history of whatever the complaint patient tells, the signs and symptoms, a thorough clinical examination, and objective testing, which are all mandatory. So the most neglected part when a patient comes with a complaint is the art of listening. So we need to allocate much time to what the patient says, because whenever a patient comes with pain, it's also the emotional state of the patient that is most affected. So we need to listen to him, ask him diagnosis in a better, strong patient clinical rapport. So when we want to diagnose, we need to have five important, that is the knowledge. So of all the problems or all the diseases that is affecting the pulp and periapical tissue. We should also have an interest in taking up the patient chief complaint, doing the objective findings, and reading the radiographs. And also we need to have a curiosity of what other problems also the patient may be suffering. And intuition, we need to see what unusual things or unusual findings we may come across during the diagnosis. And most of all, the patients, that is what is required. So history can be a past, present of medical and of dental. And this is the medical history form, which has to be provided to the patient to fill in while he is waiting in the reception. So the subject information is what the patient provides. It starts with the dental history and the medical history. The chief complaint, whenever a patient comes with a complaint, it has to be written or recorded in his own words. And if the patient is a minor, we need to take it from the patient, parent or the guardian words. And whenever a patient explains his chief complaint, it's not only the words he speaks, it also comes with the gesture. There is a hand gesture. And sometimes he points to the area where the pain or the other symptoms is explaining. So the presenting illness, and it determines the severity or the urgency of the problem, and we need to direct the question which provides how, when, and where. So that should be the question directed to the patient, not a question which provides an answer of yes and no. So that doesn't provide a full problems the patient is suffering from. So why we need to take an history? We need to take an history to know why the patient has sought the attention of a dentist. Is there any treatment that has been undergone previously that influenced the condition of the pulp, when the problem has begun, and what are the positive or negative influence is present in complaint, like your heat, cold, pressure, or a mastication. If there is a problem, a pain, we need to know its location, whether the entire jaw or a part of the tooth, which anterior or posterior, we need to know its location, its origin, whether it's spontaneous or provoked only on taking any cold or heat, its reproducibility, its character, whether it's a sharp, dull, lingering, or thrombing, whether it is continuous or intermittent, or whether there's any postural changes. So the pain usually has two components. That is the perception of the pain, which is influenced by the anesthesia. Sorry, again, I think it's okay. Reaction to the pain, which is mainly the emotional state of the patient that is influencing. So what we should know is all the nerves are alike in that they transmit the electrical impulses. So what they differ is the type of sensation and the conduction velocity. So pain is, pulp is one such excellent tissue where all the responses what is delivered will be taken up as pain because there is only nociceptor receptor that is present in the pulp. So other symptom other than the pain can be swelling, the food lodgement, or the discoloration. So medical history, though it is no systemic contraindication is present, it is of medical legal importance, and also antibiotic prophylaxis may be indicated in case of rheumatic heart fever or any prosthetic replacements. And also we should know, because of many cross infections that may happen, we also need to know what enhanced protection we need to take care. So this is the general form of both medical and endodontic history that has to be given or which patient can fill. So once the subject information is obtained, we need to go on to the objective information, which includes the clinical examination, which has to be both extraoral and intraoral. So extraoral, we need to assess for the facial asymmetry, cutaneous fistula, lymph node enlargement. And intraoral, we need to see both soft tissue and hard tissue. Since ours is an endodontic branch, though soft tissue should not be neglected, the most part of it is the integrity of dentition, caries, fracture of the cusp, discoloration, presence of any faulty restoration, wear of the tooth, or any other abnormality. So we need to also see for oralizing status, which provides how aware the patient is about the oral hygiene. Periodontal status also should be known, which may influence the treatment protocol that has been established. And when we see a clinical examination, it's very important to have better comfortable position of the patient, good instruments of diagnosis to be isolated and under magnification. These are the requirements for having a better clinical examination. So once clinical examination is done, we need to see for extraoral lymph node enlargement. So there are most often submental, submandibular, carotid, auricular, and superior and deep cervical lymph nodes. So any acute infection is there, all the nodes that will be large, soft, painful, and mobile. And any metastatic cancer, the results in stony hard nodes, which are fixed to the underlying tissue. And chronic infection, again, the only difference is that it is less painful compared to your acute infection. And how we do a palpation, it's always with the index finger, or we can do a biomanual examination with the two index fingers in a rolling motion. And first, always we need to do a contralateral normal tooth. That is most important. Make the patient aware how the normal palpation or percussion, for any matter, the pulp vitality testing also. So tooth mobility, all of you know, like Miller's mobility, grades of mobility. So we need to start with a finger and a back end of an instrument, or we can use two back end of instruments to analyze the mobility of the tooth. We can also use instruments like periodontometer, mobilometer, perio test, or photometry method to analyze the mobility of the tooth. Percussion test, it's a very good indicator of presence of inflammation in the periapical area. So that doesn't always mean that the pulp is involved. So the periapical tissue may also be involved when the tooth is vital in case of traumatic occlusion. So it should be carried both in apicoronal as well as buccolingual direction. And we need to start with the finger tapping, and gradually we need to increase the intensity so that the patient should be comfortable in taking up the test. So this is how we start with the index finger, then continue with the handle of the mirror. First provide a light pressure, then you can continue until the patient is able to provide the palpation and a percussion. It's useful when we suspect of a bone large radiolucent area to know whether there is a bony crypt that is present. So what we do here is we keep a forefinger of one hand over the apical part and we gently percuss the tooth. So if at all there is a bony breakdown in the apical area, we can feel certain amount of vibration, which can say that there is a definite periapical disease. So radiography, I'll be talking only about traditional or conventional radiography. The digital part, all students are well versed in using it. So what application we have in the both conventional as well as digital. We can analyze the presence of carious lesion, whether any restoration that is vicinity to the pulp tissue, presence of any pulpotomy or treatment, resorption, any periodical radiolucency, origin of the fistulous tract by inserting a gutta percha and taking an X-ray. We can analyze we can come to know the source of the tooth that is offending, radicular fractures or PDL widening. And if at all we want to do a root canal treatment, if we want to know the number of roots, number of canals, width of the pulp cavity, the length of the root, thickness of the dentinal walls, radicular curvature, any prior root canal therapy. So all those things can analyze. So radiograph is the most important test that has to be undertaken, that too after completing both subjective and objective testing. So how do you take a radiograph? When we take a radiograph, it should not only that particular tooth, and there should not be any cone cut. The entire tooth and subordinate structure, adjacent tooth also should be covered, and it should be viewed under good light source, preferably with the help of a magnifying lens, and not one X-ray. We need to take different X-rays of different horizontal angulations. And by doing radiograph is also helpful in order to know the information regarding the pulp chimp, and also how carious lesion is approaching the pulp. So radiographically, the radiolucent lesion in the prepuce is visible only when the cortical bone is involved, and the amount of destruction that is visible radiographically is comparatively less. So clinically, much more destruction would have taken place. So there are some illusions that happen with the radiograph or conventional radiography, even digital for that sake, because it's a two-dimensional image what we are seeing. So this is an image where we can see that there is a radiolucent area involving the lateral incisor, but on vitality testing, the central incisor, lateral incisor was vital. So root canal was performed. There was a disappearance of the radiolucent area. The same with this, the lateral incisor seems to be the tooth which is offending. Also, you can see some amount of resorption-like thing in the lateral incisor, but it was actually the canine which was non-vital, and the radiolucent area extended onto the lateral. So it also depends on the projection angle, the amount of bone that is removed. So all this affects the radiographic appearance. Again, here you can see a large restoration with the molar and a carious lesion involving premolar. So we can suspect that both molar and premolar are affected. But on vital testing, again, the premolar is the one which is causing, which is having the radiolucent area. The same with this. So like that, there are different illusions that can happen. So we need to be careful, take 2 or 3 angulations, analyze the movement of the radiograph, movement of the radiolucent lesion, and association of with which tooth. Again, this tooth, so what happens here is a large radiolucent lesion covering almost the lower incisors. So if at all we don't do a pulp testing and directly go with X-ray, we tend to do all the 3 tooth root canal treatment. So what is actually required is, we should not jump into a conclusion, do other vitality test or sensibility test, determine which tooth is offending, and perform root canal treatment only to that particular tooth. And that on the right side, what you see in X-ray, you can see a small radiolucent area that is moving with the movement of the cone or the projection of the cone. So that is nothing but a nasopalatine foramen. So we need to see here the intact periodontal ligament space, which can rule out the tooth. And again, this is a lesion, though the radiograph observation is not optimal, it's not satisfactory. So this is the case of nasopalatine duct cyst. So this has to be diagnosed properly with different angulations. And all of you know how to use a slope rule. So this is very much required in our endodontic practice. So what is it? It's a same lingual, opposite buccal. So whenever we move the cone to the mesial side, the lingual is the one which is towards the cone, and away is the buccal object. So it is mainly indicated when you want to locate superimposed canals or roots to distinguish various type of resorption. Also helps in determining the buccolingual position of the fracture. Any foreign object that is present, you want to localize it, and also to locate any anatomical landmark like your mandibular canal or your mental foramen. So you can see here there is an horizontal angulation change of 20 degree. It's to the either to the mesial or distal, whatever buccal and lingual canal is there in the mesial root of the lower molar can be seen separately. The same with the upper molar. When we have a MB2 and MB1, in order to localize or visualize in the radiograph, we need to have a different angulation. So whichever the turn side we have taken the cone, the lingual will be the nearest to it. So there are some special consideration when we take a radiograph, especially when the patient is having gagging. So we need to use a distractant strategy like breathing through the nose or keeping a salt on the tongue, lifting one leg up in the air. It's all distraction strategy. And also we need to make sure that all the necessary things prior to taking an X-ray is ready, because those patients will have significant gagging problems. We can also use a local anesthetic, which may be beneficial. A patient with tori or narrow dental arch, we can use a bisecting angle technique. And whenever we have a palatal wall which is narrow and shallow, you can place the film towards the midline. So pulp testing. So, sorry, I think this slide has come up. Okay. So that ideal pulp test methods should provide a simple, objective, standardized, and non-painful, accurate, and inexpensive way of assessing the condition of the pulp. We have three terms here. The vitality is assessing the pulp's blood supply. So pulp may have an adequate vascular supply, but it's not necessarily innervated, as in traumatic injury, where there is a transient paresthesia, and also in immature tooth. So pulp sensitivity is what we do cold or heat test, where the pulp responds to a stimulus. So sensitivity is a condition of the pulp being very responsive to a stimulus. So we can have sensitivity testing of electric pulp testing, thermal test, direct dentin stimulation by means of test cavity. Pulp vitality, we can most commonly, and what is most extensively studied, is the pulse oximetry and laser Doppler fluorometry. Surface temperature measurement also provides the clue of vascular supply of the tooth. We can also use anesthetic test as a last resort. Am I audible? Yes.
Yes, sir.
Yes, you are audible.
Yes.
You can go ahead.
Yes. Okay. Thank you. So before going in how the pulp testing is done, we need to know how the pulp is innervated. So as it enters the apical foramen, it branches from the bundles to form smaller nerve fibers and then plexus of Roscoe. As it proceeds coronally, it forms a subodontoblastic process or plexus. From there, the terminal axons exit from the span cell and pass between the odontoblast as free nerve endings. So we have most of it as A delta nerve fibers, and the central part of the pulp is occupied by the C fibers. So you can see here the A fibers are myelinated, whereas C fibers are unmyelinated. A delta fibers produces a sharp, well-localized and fast pain, and it's stimulated by cold, heat, drilling, and probing. Whereas C fibers are mainly stimulated by the inflammatory mediators. That means that the pulp is already inflamed up to the central part, and it is not used. Heat is applied, which may damage the tissue. Again, it may stimulate the C fibers. So these are some of the differences. If you see the condension velocity faster than A delta, then the C fibers. C fibers are the slow conduction, and also the threshold. If you see, C fibers have higher threshold. That means that you need to give more intensity of stimulus.
Any problem? Yeah, the screen is sharing. Unmute yourself. Unmute. It's not possible from your side. Now?
Now it's clear? Okay.
Yeah. Start. Go.
So these are the differences like so A fibers and the unmyelinated C fibers. You can see the excited threshold is very high with the unmyelinated C fibers, and inflammatory mediators increase in the pulp pressure all causes stimulation of the C fibers. So we can see how the pulpitis will affect or will have an effect on these A fibers and the C fibers. So there are different mechanisms by which thermal test and EPT test act. So the thermal test, either it is cold or heat, is based on hydrodynamic theory, where there is a flow of fluid in the dendritic tubules, and this in turn activates the nociceptors, which are nothing but the delta fibers, which are present within the between the odontoblast. So C fibers are not activated by the test unless they produce injury to the pulpal tissue. And there are no thermosensing nerve endings in the pulp tissue. So it's only the pain that the pulp can take. So cold stimulates the fast current A delta fibers, which produce a sharp localized pain, and continued heat can stimulate the slower conducting C fibers. So electric pulp test mechanism is different. It's not the hydrodynamic theory. It's mainly there is ionic shift in the dendritic fluid, which causes local depolarization and generation of action potential from the intact nerves. So the mechanism is entirely different here. It's mainly the ionic shift that happens, and there is generation of the action potential. And when the pulpal flow is reduced, as in pulpitis or pulpal necrosis, when there's no blood, of pulpal condition. When we do pulp sensibility, so we do it when the patient comes with a traumatic injury, when there is a pain in the trigeminal area, or before any restorative procedures, and a tooth which has undergone regeneration. So there's a lot of disturbance in the internet.
No problem, sir. You can continue.
I was talking regarding the indication. So we also do pulp testing when we have done the transplantation of the teeth, especially when leaf-type fractures have happened and osteotomies have been performed. And what are the limitations? So all the pulp testing are subjective and only measure the pulpal response, the pulpal nerve response, not the blood flow, and may not be effective in elderly patient when there is substantial secondary dentin formation, less I guess, sir, it's audible. I think there is some problem.
Srinidhi, you are audible, man. You can go ahead. No problem.
I guess, sir.
Yeah, you are audible.
Okay. Yeah. There's it's getting disconnected now and then. Okay. So limitations include sensitivity tests are difficult to administer when used in children, and reduced neural component in the age pulp can give different responses. And whenever we have a large restoration, pulp recession, excessive calcification, there may be difficulty in interpreting the pulp test results. So what are the false responses that may happen? So we have false positive and false negative. False negative is the one where teeth have normal pulp, but they will not respond to the test. It mainly happens with the core test when there is a significant classification, when the patient have been pre-medicated, when the tooth has been involved in the recent episode of trauma, when extensive restoration and pulp rating bases have been kept, and when there are EPT itself is defective, either with a battery or a poor electrical contact, following activation of the orthodontic appliance. False positive is the tooth is necrotic, there is no nerve supply, but the tooth gives positive response. So that may happen when there is a conduction of current to the adjacent gingiva. There is liquefaction necrosis, breakdown products of localized necrosis. Calcified tooth structure might be capable of conducting to the tissue apical to the pulpal necrosis. And when there is a tooth with metallic restoration and is contacting the adjacent tooth, a tooth with multirotated tooth with necrosis in one or two canals and a vital tissue in one root, and also positive response can occur in an anxious or young patient. So why cold, which is reliable, cold or EPT? It's always the cold. It's because false positive response is very rare with the cold, and the tissue which is responsible for the response to the cold is lost earlier compared to the EPT that is the other C fibers. So response to the cold always requires more live tissue in the coronal aspect of the tooth than does the EPT. And heat, though it has good sensibility, but it lacks specificity because it doesn't properly detect the absence of the disease. So value of the diagnostic test can be explained in the terms of precision, accuracy, sensitivity, and specificity. The precision is a tendency of repeated measure to provide the same sample to get the same result, whereas accuracy classifies the patient response correctly every time it is done. So sensitivity is the ability of the test to detect the disease in patients who actually have it. Specificity is the ability of the test to detect the absence of a disease. And you can see in the this picture, the first A picture has high accuracy. So the central part of the dot is always pointed, but precision is very low. In the second diagram, the precision is good, but the accuracy is less. So this is how the treatment the test can be classified. We can also evaluate using positive predictive value, which says that a positive test results actually represent a disease positive tooth. Like that, we can use a negative predictive value. And coming to the pulp testing, so as a rule, always the cold sensitivity appears first. When the pulp is deteriorating, the heat sensitivity occurs, and whereas the cold disappears, finally, is the cold stimuli is the one which relieves the pain of the pulp, which is induced by the heat. That's the rule. So damage to the soft tissue, whether when we use a cold, it's very rare, especially when we use for more than a minute, because all the cold tests are done for seconds, 5 to 25 seconds, depending on how the patient provides the response. So if at all we use a carbon dioxide or dry ice, there have been incidents of new cracks in the tooth or pitting of the porcelain. That may have been for as little as if at all we apply for 5.4 seconds. So cold test, it's always the A delta fibers that are stimulated during cold testing. For the dental plane to be evoked, the PDJ, that is the pulp dentin junction, should cool to 29 degrees. So we have different methods: ice sticks, refrigerant sprays, carbon dioxide snow, ethyl chloride, and cold water baths. So in this, ice stick is most commonly available in everybody's clinical practice. We can use it in a plastic covers of a hypodermic needle, or use a anesthetic cartridge. After sterilization, we fill it in water and keep it in a fridge. So we can take out that ice stick and cover with the gauze, isolate the tooth, and place it in the middle third of the label or lingual. Label is more appropriate. But ice sticks are not very reliable. So the temperature is not sufficient enough to lower the temperature at the pulp dentin junction and to evoke a stimulus. So refrigerant spray have been widely used, easily available, and they are based on three, that is dichloro-difluoromethane, tetrafluoroethane, propane butane mixture. So this temperature ranges from -20 to -50, and it's also effective in patient who is having Crohn's. So tetrafluoroethane is most commonly used. Dichloro-difluoromethane has been banned because of environmental concern, and the manufacturer is replaced with 1112 tetrafluoroethane, which is available as green endo ice with a temperature of minus 26.2. So what is most commonly used is the PBM, that is propane butane mixture. It is available as endo frost with the temperature of minus 50. It is applied onto the cotton pellets or to the cotton rows and immediately place it onto the label aspect of the tooth. So the in vivo temperature of the endo frost is minus 20. So though it is minus 50, when we apply it on the tooth, the temperature decreases to minus 28 degrees centigrade. And carbon dioxide snow, this is well documented, more reliable and accurate. And the main advantage of this carbon dioxide snow is, and there's a direct sublimation to the gas form. So when carbon dioxide, though it's a gaseous, under a solid state, it forms a dry ice. So this is a tank, carbon dioxide tank, which is then passed into a plexiglass container and compacted with a plugger to form a dry stick of dry ice. And it is immediately placed in the middle third of the tooth for it's more, the water may flow onto the adjacent tooth also. The carbon dioxide snow doesn't have that disadvantage. It gives an intense reproducible response. There's no need to isolate as in other cold tests. Even ice stick needs an isolation, and cold water bath is also requires an isolation, and also effective against So disadvantage is that it's very expensive and not effective in patient who has an evidence of calcified pulp and extensive amount of secondary dentin formation. So there's a phenomenon of leaden force. There's a viva question for all of you. That occurs when a small amount of carbon dioxide snow enters the oral cavity, but it not causes any burns, soft tissue burns, because there's a sublimation directly to the gaseous state. So there is whatever the ice stick is there, it's covered by a gaseous layer. So that prevents any tissue injury that happens. Ethyl chloride, though it was initially widely used, nowadays it's not very commonly practiced because any breathing is vapor. More than 50% is very fatal. So it's a topical anesthetic also, and it's supplied in a spray bottle, which is propelled by its own vapor pressure. Cold water bath, the main important criteria here is to isolate a tooth or a group of teeth, and we need to use a syringe cold water onto the particular teeth. More reliable, but only needs more time, and we need to isolate each particular tooth and syringe. Whereas difluoromethane has minus 50, endofrost also has minus 50, whereas the in vivo temperature is comparatively less, but better with the carbon dry ice. Heat test. So heat test mainly causes the fluid to expand, stimulates the A delta fibers, and if at all the heat is applied to an inflamed pulp, the pressure can also stimulate the C fibers and produce a long-lasting pain. That's why the specificity is less. So that's why the cold is more reliable. Pain precipitated by heat usually shows an acutely inflamed or a partial necrotic pulp. We can use a Gataparcha, warmed instrument, electrical heat source, frictional heat, like cold water bath. We can also use hot water bath. So, and one more important problem with the heat test is most of the pulpal necrosis harbors bacteria which produces gas. So this gas expands when applied heat, and this may stimulate the C fibers also. So hence, when there is a small pulpal abscess, heat can increase the symptoms and bone. So we can use heated gut aperture by use of Grossman method, where he says we need to isolate the tooth and dry the tooth surface, protect the tooth with a light coating of petroleum jelly, warm the gut aperture middle third of the facial or lingual surface, or with a temperature of 130 to 140 degrees centigrade. So reproducible results cannot be obtained with the heated gut aperture, and stimulus always depends on the amount of heat that's transferred, the amount of heat that's present in the GP, and the area of contact. So here again, so where I was, Nagesh sir. Anybody can respond.
Sir, no, sir, continue, sir. Sir.
Continue, okay.
Yes, sir.
Yeah. No, you please
What
respond,
happened?
okay, because there is a lot of
nothing.
disturbance.
You are
Nothing.
going well.
Nothing.
Ethyl chloride somewhere you are there. Just go ahead.
Okay. Yeah. So heated gut aperture, we need to warm it over a flame until it glistens and place it on the middle third after isolating and drying the teeth. And it's warmed hand instrument also can be used by heating a ball burnisher of the flame, but it's not very reliable because the amount of heat that is transferred to the tooth is questionable, and we can't directly place the ball burnisher over a tooth. We need to just rely on the radiant heat energy that is transferred to the tooth structure. And we can use electrical heat sources like our System B or a touch and heat device. So we have a special tip like hot pulp test tip where we can heat it to 150 degrees centigrade and place it on a tooth which has been properly lubricated. Friction heat can be used by means of a rotating rubber cup, and especially done when we have a metal crown which transfers the heat to the underlying tooth structure. We can also use a hot water bath like our cold water bath, and we need to position the patient in supine, and most posterior tooth is isolated. And once it is syringed, we need to analyze for the patient feedback. And we need to use a heavy rubber dam to withstand the temperature of the hot water bath. And whenever we are testing, we need to know certain concepts like always inform the patient what we are doing. So how the results are accepted. So if at all we are applying cold, we need to explain to the patient the nature of the test. And also explain to the patient or instruct the patient to raise his or her hand when they feel the sensation and keep their hand up until the sensation is present and lower their hand when the sensation disappears. This is what is very important. If there is no sensation after 5 to 6 seconds, we need to stop the test. So once the pulp is tested with cold, always there is a refractory period. We need to wait for a few minutes until again cold test is done. And which aspect of the tooth we need to place, either it is cervical, buccal, or incisal, or labial, middle third, or incisal. There is a lot of controversy regarding this, and most appropriate and most of the articles says it is the middle third of the tooth that has to be kept. And before starting with any particular tooth, we need to first do the contralateral teeth, then opposing teeth, and preferably healthy tooth on the same arch and the fitting tooth. So this is the way how we perform a pulp sensibility test. So coming to the electrical pulp testing, this was actually attributed to Maggie Todd and then Marshall, and it's primarily particularly effective in older patients and teeth that have limited fluid flow through the dentin tubules. What is the physiological basis of this electrical pulp testing? So when a sensation that is felt by the patient is mainly because the electric current is passed through the tooth and there's a direct stimulation of the nerve fibers. And this necrotic or disconnected pulp tissue leaves electrolytes. And again, this may help in conduction of electrical current. And one more important factor is the thickness of the enamel dentin, and this may provide some amount of resistance to the passage of current. So C fibers are the last to get stimulated. A-letter fibers are one which is stimulated by the electrical testing. And the principle is to raise the electrical potential through the enamel and dentin to provoke a measurable response from the pulp. And the direct current, which has been pulsated with a duration of 5 to 15 milliseconds, is the best stimulation for the testing. So the electrical stimulation depends on the rate of current, its increase, its strength, that is voltage and current that is applied, the duration, and the frequency. So if we increase the surface area of the electrode, we need to provide more of current. And each stimulation, like every individual has a threshold stimulus. So we need to know this threshold stimulus by comparing with an contralateral healthy tooth. So we have two types of EPT, monopolar and bipolar. What commonly we use is the monopolar, where we have single electrode. Bipolar, we have two electrodes which are placed on the tooth, and the current passes from one electrode to the other. We also have benchtop or handheld devices, and most EPTs are monopolar, and with the anode often the lip clip and cathode being the probe that is kept on the tooth. And the circuit is always completed either by the use of lip clip or by the body of the practitioner or by the patient itself who is holding the end of the probe. There is always a negative correlation between the positive response to the EPT and histological status. A positive response means that there are sensory fiber present within the pulp that can respond to the electrical stimulus, but histological evidence is lacking. How do you use it? It's always we need to remove the calculus, clean the tooth surface of the tooth should be dried. Any metallic restoration is there in the particular tooth should be insulated either with the rubber dam or cellular strips. Then circuit should all completed by use of special lip clip. That is always preferable compared to using telling the patient or we touching on the patient face. And we need to use conducting media, the special electrode gel. The result should slowly increase. So we have a rheostat provided with the unit. We can use the rheostat to slowly increase the amount of current that is passed to the tooth. So we have a number from 1 to 10, 1 to 50 or 1 to 80. That is a rheostat that is numbered. If the response is not obtained, we need to place it on a different location of the same tooth. So we need to change the location 2 or 3 times to ensure consistency and a result, average result is recorded. It can be prepared through the restore. If a crown is there, we can prepare a cavity and the probe directly on the dentin, we can evaluate the response. If at all patient, if the clinician is having is gloved, if at all is not gloved, you can directly use the other fingers of the hand to complete the circuit, or you can use a lip clip that's provided by the unit, or you can tell the patient to hold the probe of the unit to complete the circuit. So there are some variation in the reading that may be because maybe problem in the equipment or in the probe placement or in the interface media. We need to first make sure these are in proper way. Or tooth characteristics like an excessive enamel wear or more thickness of enamel is there, calcification is there, cracks are there, all will have an effect on the response by EPT. If there is periodontal disease, again the threshold will be reduced, so the EPT will be false positive response may be there. Patient-related factors like the psychological state of the patient, physiological state, like if the patient is hypertensive, has higher threshold, stimulus threshold, and patient who is having endocrine disturbances or patient with having effect CNS disturbances and drugs where narcotics, analgesic, will have. So EPTs may not mature enough until 5 years after tooth eruption, and it's also not effective enough when we use a full coverage restoration, And there have been concern with the pacemaker, but functioning. And there is also some concern here that the mechanism of stimulus is different for the EPT as well as the cold testing. So we can conveniently conduct EPT testing soon after the cold testing. So this is how we have taken. I'm keeping the references soon after each part, so you can go through the references. So test cavity is again anesthetic cavity. Both are of the last resort. Test cavity usually done when the diagnosis dilemma is there, when the patient reports cavity without anesthetizing the tooth. Once we reach the dilemma junction, if the pulp is vital, patient will respond. So we can stop the procedure. We can fill the cavity and search for a offending tooth. We can also do this procedure in a full crown restoration, where we can remove, do a hole in the center and reach the dentin and assess the condition of the tooth. But the problem here is it is invasive and it's not reversible. So in the modern practice, for the best interest of the patient, better not to do a test cavity. So anesthetic test is again the last resort when the diagnostic tests are inconclusive. So anesthetic test cannot identify the tooth, but it can identify the zone where the responsible tooth is present. When we have a pain in the lower jaw or upper jaw, whichever the patient is, the side is telling, is not specifying either maxilla or mandible, we can first give off the mandible nerve block. Once the patient tells the pain has been reduced, we can comfortably tell that the pain is coming from the mandible region. If it is not subsided, we can go for the maxilla. So now in the maxilla, we can go for infiltration anesthesia, starting from the most posterior tooth, coming towards the anterior. So we can analyze or point towards a single particular tooth. Transillumination is actually done when we have a cracked tooth. We can either use a high intensity light fiber optic device, or we can use high intensity our curing light itself. Where the crack is there, we can see a small dark line which represents the crack, and we need to do this test only after removal of the restoration. So by test, a moist cotton can be kept over each fragment, stretching of the plastic process and sensation of the pain. Now we'll go with the test which measures the blood flow. So am I audible? I'm there, Rupa? Anybody?
Yeah, you are audible.
Okay. So pulse vitality, we have invasive and non-invasive. So what we follow, what is most commonly studied is the non-invasive methods. So in that, laser Doppler and pulse oximetry are the main methods which has been studied. So laser Doppler flowmetry, so it's mainly useful in a traumatized teeth pediatric patients and to diagnose any non-hygienic differential diagnosis of the non-hygienic periapical pathosis and to assess the blood flow. So it was first introduced by Gazilis in dental literature. It's a non-invasive, semi-quantitative, and it is reproducible. So what is actually it is? So it is like a light is made through pass through a tissue sample. If at all there is a moving object, that is mainly the red blood cells, whatever the light is passed, it gets frequency shifted. If at all a non-moving object is there, like a static tissue is there, there is no shift in the frequency. Now this will be taken by the detector which is present in the probe. So the probe is a single probe which contains both the light source as well as the detector. So the light source is a helium neon laser which with the wavelength of 632 nanometer. We can also use higher wavelength to produce better penetration in the form of semiconductor, that is 1 to 2 millivolt of the laser power. And this is how the mechanism is. So a light is incident onto this tissue. So a moving red blood cells, when it come across this, it gets reflected, but this reflected light is frequency shifted. When the light is reflected from a static tissue, there is no frequency shift. So once the light goes back to the detector, the signal is provided in the form of a flux. That flux will provide also the machine gives a perfusion ratio, but this is very arbitrary. That doesn't give proper perfusion ml of blood per milligram of tissue. So it's an entirely arbitrary. So we need to also, the device has some analysis called fast Fourier transform analysis. So when we have a vital tooth, we have an amplitude at 2. We can see 2 hertz. At 2 hertz, we have an amplitude. This is performed in a dog. So the dog at 2 amplitude, it responds to 122 heartbeats. So like the hertz. So that vital or non-vital. So this is the device where we have a probe which provides the light as well as the takes up the signal. So mainly indicated to monitor the local and systemic pharmacological agents, monitor the exercise on the pulpal blood flow, age-related changes, orthodontic procedures, after orthodontic surgery, revascularization procedures, after any traumatic injury. So it especially measures the pulpal blood flow. And also it is comfortably can be done in the children's. So what are the factors that affect? So flowmetry. The main factor here is the choice of bandwidth filter to reduce the noise and wavelength of the laser source and the fiber separation within the probe. So 250 or 500 microns is the fiber separation that is indicated. The probe angulation also doesn't matter significantly, but probe position is a must. So we should keep this probe in the middle third away from the gingival tissue, because non-pulpal signals may also be taken by the probe. And probe hold, positioning of the probe and tooth type, premolar, incisors are all been tried, but there is no significant difference in the signals that is received depending on the tooth type. So we have different holders. The putty also, we prepare a hole in the putty. After taking the molding or after placing on the teeth, we can prepare a small hole, and through that hole we can place rubber dam or with a cotton roll, or we can use a periodontal paste. The limitation issue that will have an effect, though this technique is semi-content and extraneous noise like loud sounds, movement of the apparatus itself can flow in adjacent tissue. Tissue is that it limits the penetration of the light. So this has to be taken into consideration. When we use in a pulpless and a vital teeth, on an average, there is 37.3% less output signals compared to the sound teeth as per Reberg et al. And also when there is an pulpitis, when there is increase in the concentration of the red blood cells, which indicates increase in the pulpal, actually the signal will decrease. So this can be compared with the vital tooth. Pulse oximetry, again, these are Japanese researchers, the Beer law and Lambert law. Beer law says the absorption of the light is proportional to the concentration of the sample. So what we are measuring is here oxyhemoglobin. Lambert says that is the absorption is proportional to the thickness of the sample, and we can use this pulse oximetry. So basically it has in the range of 900 to 940. So once the light is placed either in the finger or the earlobe, the light passed through the sieve, which is not absorbed. So the light which is transmitted. So the light that is transmitted will be taken by the photodetector and then analyze the signal. So we have hemoglobin which is oxygenated and deoxygenated. As you see in the graph on the right side, the oxygenated hemoglobin absorbs more of infrared light, whereas reduced hemoglobin absorbs more of red light. So this ratio is taken into consideration. So as all of you know, hemoglobin is made up of 2 alpha unit and 2 beta unit, and it available in 2 forms, taut and relaxed. Since there are 2 configurations, the light absorption will also here in the graph on the left side. So we have a tissue which consists of an arterial blood, a venous blood, stationary tissue, and this is plotted against the time, and we obtain a ratio of the red light as well as infrared light, and we provide a saturation of the oxygen. So what you see in the arterial blood is always there is an increase in the blood volume as per the cardiac cycle. So during the systole, there is an increase in the blood volume, whereas in the venous capillary blood, we don't have an increase in this volume. So this volume increase also influences the amount of light that is transmitted. So this is taken into consideration by the device, and a graph is, plethysmographic graph is obtained, where you can see in this amplitude, when we have a ratio of -34, it's mainly the deoxygenated blood that is present. And when the ratio is 1, we have 85% oxygen saturation. When it is 0.43, then we have 100% oxygen saturation. So this can be used. So, and always when this LED operates, it's on and off. So the red light ons, the infrared light ons, and again both will off. Like that it does 30 times per second. So there is not continuous illumination, there is on and off, and the light that is transmitted through the tissue, not the reflected one, what is transmitted is taken up by the detector. So it's mainly indicated when in a recently traumatized teeth, and when we want to assess the pulpal oxygen saturation in primary and immature tooth, and whenever we are using a sedation technique to treat medically compromised patient. So again, there are many factors that may affect the result, that like low perfusion, we have peripheral perfusion, we have hypotension, vasoconstriction because of the anesthesia, like probe movement, overhead light, and the problem with the probe itself, all will have an effect on the result. And one more important part here is, whenever we place a sensor, the detector should be in parallel. So it should be parallel to each other. You can't have a curved surface here. That is the main limitation when we use on the tooth. So we need to have a special adapter or on the tooth, so that sensor can be kept parallel to each other and a recording can be obtained. And Pulp contains more of arterioles. So the pulse oximetry mainly measures the oxygen saturation in the artery, so where it is pulsating. Though there's few authors have told the Pulp contains a thin wall, which accounts to the pulsatile nature, but still the results are questionable. The value of the test, Radhakrishnan et al. Have found that the oxygen saturation reading and electrical test readings are inverse. In the sense, when we have a higher reading in EPT, the oxygen saturation decreases. And also, Gopishan et al. Have found that the sensitivity of the pulse oximeter was 1 compared to 0.81 of the core test and 0.71 of the electrical test. So the sensitivity as well as the specificity of this pulse oximeter is comparatively better compared to the core test. So these are the probe where it is placed on the rubber dam clamp or an earlobe that is been modified by Guha et al. And Gopishan et al. Has made a custom-made probe where the sensor have been kept. So these are the documented in the literature. As you see, this is the specificity and the accuracy of many cold testing as well as heat testing and the pulse oximetry, combined pulp testing as well as the pulp vitality. If you see this, the laser Doppler flowmetry has a very good sensitivity and specificity compared to, second is the pulse oximetry, and then is the cold test. So tooth temperature measurement, again, it comes with the measurement of blood vasculature. So what is the source of heat? The heat is conducted from the periodontal tissue or by the circulation of the pulp or by the metabolism of the pulp. So when we analyze the temperature in the tooth, it's mainly the conduction as well as the pulp metabolism and the circulation. So non-vital tooth doesn't have this pulp metabolism and pulp circulation through which we can come to a conclusion. So there are different methods by which temperature is measured: thermocouple, infrared thermometers, thermistors, cholesterol crystals. So what is commonly used is a thermistor and Hughes probe camera, that is infrared thermography. So cholesterol crystals are nothing but a 10% solution by weight of cholesterol esters in a chlorinated hydrocarbon solvent. So this at a mesophase stage, they are neither liquid nor crystal. So they exhibit different color at different mesophases. This can be according to the temperature that is present on which it is placed. So usually it is coated onto a black strip. The uncoated is placed on the tooth, whereas the coated one is placed above. The color that result should be matched against a color map on which we can tell which temperature it is, whether it is there is a temperature change or not. And the most disadvantage is that the oral temperature also has an influence on this cholesterol crystal strips. So thermistor are nothing but electrical resistors. Means according to temperature, the resistance varies to the flow of current. They are mainly act as a sensors. It has a high sensitivity and a low heat capacity, and we can use it to analyze the rewarming of the tooth when it is reduced to a lower temperature. So Hughes probe camera can detect changes as low as 0.1 degree centigrade, and it also helpful in analyzing the rewarming of the vital tooth. So ultraviolet light has also been used to know whether there is any fluorescence in the particular tooth. A vital tooth has a property of fluorescence, whereas necrotic tooth and the tooth which has been endodont treated doesn't fluoresce when exposed to the UV light. So we have advanced radiographic images like digital radiography, CBCT, MRI, and ultrasound. Digital radiography I'm not going to cover because it's again extensive, and many of you know how to manipulate the images in the software. So CBCT is mainly contains a rotating gantry on which the source, X-ray source, and the detector are fixed, and it is moved in the arc of 180 degree in the field of view, and it provides a precise, immediate, and accurate 3D images. So depending on the scan volume, we can have a localized region, single arch, interarch, maxillofacial, and craniofacial. For endodontic use, we always have to use a localized with approximately 5 centimeter or less, depending on our application. The smaller the scan volume, the better is the resolution of the image. Since we need a better resolution, the resolution should not exceed 200 microns. That is the average. Diagnostically very useful because it provides the image in 3 sections. That is the axial, coronal, and sagittal. So we can use the buccolingual, mesodistal, as well as the axial sections to analyze the morphology of the tooth, and also analyze how the treatment has been performed. If at all we want to know the lesion size also, we can use the CBCT software to analyze the volume of the periapical lesion. Radiation dose, all effective dose is measured in microsieverts, and CBCT provides a radiation exposure of 0.4 to 2.7 digital panoroping equivalents. That is high. So the radiation dose is really high. That's why only when and where required, we need to use a CBCT to diagnose either during the treatment or before the treatment. So most useful for knowing the morphology of the tooth, and also to know whether there is an periapical bone defects, and we can use it CBCT for pre-surgical assessment to know the any resorption present, any proximity to the landmark like your mandibular canal or your mental foramen. And also CBCT can be used to know what is now a dynamic navigation system. And also we can use CBCT image for producing a template assisted surgical endodontic surgery, and also a dental trauma, resorption, assessment of root canal morphology. So the incidence of location of the canal increases when we use a CBCT, whereas vertical root fracture is not that efficient because we have other radiopaque structure within the canal, like your GP metal post that cause beam hardening. But there are, in addition to the software, which eliminate those. So what is required for our endodontics? So we need to have high detail and high resolution images, and but high image resolution comes at a high radiation dose, and all exposure should be a limited field of view scans. And the limitation include the presence of metallic restoration, and even the gutta percha can cause significant radiographic artifact. We have metal artifact reduction algorithms where it uses the adjacent grayscale values to know the boundary between the metal artifact as well as the adjacent tissue. So these are some of the CBCT images where we can use or diagnose external cervical resorption, the portal of its entry, the size, and its precise location. Whereas in periapical radiograph, we can't actually tell which area, either the labial, mesial, or lingual side is affected. Here is a case of a mandibular molar, second molar. The extent of the lesion, the size of the lesion can also be determined. The presence of the canal, how many canals also can be determined. And here is again PR radiograph of a failed root canal case. You can distinguish a second mesobuccal canal which has been missed. And you can see in the middle radiograph where there is no presence of periapical lesion. But on the CBCT, we are able to distinguish a missed distobuccal root and a large periapical lesion of both mesobuccal and distobuccal root. The same with the lower part of the figure, we can see a large radiolucence affecting the mesobuccal root, which is not evidently visible in the periapical radiograph. In the lower part of the CBCT axial sections, we can see a resorptive defect on the lingual side, and on the right hand lower bottom, we can see a fracture of the apical part of the root with the loss of cortical bone. So this is all possible with the use of CBCT. And also we can analyze the volume of the radiolucent lesion, and accordingly we can give a periapical index score as provided with the periapical radiograph, conventional periapical radiographs. So American Association of Endodontics and American Academy of Oral Maxillofacial Radiology has provided a position statement where to use CBCT. So intraoral radiograph is always preferable for the initial evaluation of the endodontic patient. We can use a limited CBCT when we want to diagnose a non-specific clinical signs. And again, it is indicated when we want to locate the extra canals, when intra-abutment identification is required of the calcified canals. And again, immediate post-operative imaging is required. Then again, we need to go for a conventional radiography. And vertical root fracture is again, the use of CBCT is limited, but still we can use more often, we can detect in the conventional radiography itself. Non-healing previous endodontic treatment is there. We can use a CBCT to analyze non-surgical retreatment. Complications like your separated instrument, perforation is there. We can use an CBCT. Pre-surgical planning, and also in case of dental trauma or in a case of resorptive defects. So based on the CBCT imaging, Estrella has provided a periapical index score depending on the size. So he has given from 0 to 5 and also added score E and D. Score E is expansion of the periapical cortical bone. D is a destruction of the periapical cortical bone. So both are different. So when there is a proper destruction, we can see a direct, when we do exploratory surgery, we can directly access the root tip. So depending on the size, he has given the scoring. There are also studies where they have considered the volume of the lesion, whereas Estrella has taken the largest distance between the periapical lesion when taken as sagittal, coronal, or axial section, which are the largest. He has taken that measurement. Whereas in another study where they have taken the volume of the periapical lesion has taken into consideration, and also they have added D and E score as per the Estrella et al. And They have provided D1 and D2 depending on the effect of the cortical blade. So again, map reading is one more strategy to diagnose the perforation when a metallic object is there. So what they say is we need to take a sequential axial sizes of 0.2 mm each. So this mapping provides exact localization and communication between the root canal and the periodontal ligament. So ultrasonic imaging, again, it's though it's not widely used, has been studied as a main diagnostic tool to differentiate the periapical diseases, either between granuloma and a cyst. So most of the periapical disease, though they were able to tell depending on the size or outer rim in the radiograph, the precise location, precise diagnosis can be done by use of ultrasound. So what does ultrasound does? It has a either quartz crystal or a synthetic ceramic crystal. You can see a probe there. We have many crystals that has been arranged. When a current is passed, it deforms and it forms, it sends signal, that is a vibrating signal, and this is bundled by use of acoustic lens, what you see in the probe design, and this is sent to the tissue. So this waves comes back to the probe. Again, the probe receives the signals, and that is in the form of echo. So this is the picture where you can see when an ultrasound beam is projected. So these waves undergoes scattering, refraction, accentuation. So whatever is reflected back is taken by the transducer, that is the probe. So this probe takes up those signal, again converts those into a electromagnetic waves and then into a light form. This is converted in the computer in the form of a grayscale. So the intensity of the echo depends on the acoustic property or the acoustic impedance of the tissue. Greater the difference, greater the reflected ultrasound energy, higher the echo intensity. So this, there are four terms. Hyperechoic is the one where the echo intensity is higher. Hypoechoic is the one where we have low echo intensity. And when there is absence of echo intensity, is called anoic. So whenever we have a fluid-filled area, as in the cyst, we don't get any echoes. So, and whereas bone, there is total reflection that occurs. It appears as a bright area. It's hyperechoic. And when we have different types of tissue, like in a resorptive area, so this provides this homogeneous echo. And if we supplement this ultrasound examination with a color Doppler color Doppler, we are able to analyze the perfusion of the tissue. This is very important because granuloma has vasculature within the lesion, whereas cyst has on the border. So this can be analyzed when we have color Doppler, and we can differentiate between the both. Now this is the probe design, and we need to have a gel, and this ultrasound wave can be enhanced if at all we use a contrast media. This increases the echogenicity of the blood. So this is how the tooth and the surrounding structure appears. The ulnar bone, if it is healthy, it is hyperechoic. The roots are also hyperechoic. If at all we have a solid lesion in the bone, it is hypoechoic. If at all the cavity is filled with clear fluid, it is anoic. If at all it is inclusions are there, if it is hypoechoic. And if at all is resorbed, it's a dishomogeneous echo. And we have a bony contour, as in the cyst, it is hyperechoic. And if at all we apply color Doppler flowmetry, we can also direct, we can detect the presence and direction of the blood flow. We can also distinguish the mandibular canal and mental foramen since they are anoic. So if at all we compare a cystic lesion and a granuloma, cystic lesion is transanoic, that is a cavity which has a well-contoured cavity filled with fluid surrounded by reinforced bony walls with no evidence of internal vascularization. That is very important. So this is where we can differentiate a cystic as well as the granuloma. You can see here, this is a cyst where there is no evidence of any vasculature in the central part. Whereas this is a granuloma where you can see many blue and red light, that is depending on the direction of the blood flow. If at all it's towards is the red, away is resonance imaging. This also have been tried So am I audible? Again, it's got disconnected.
Sir, you're audible.
Okay, sir.
Sir, you're audible, sir. Rupa. Sir, you're audible.
Yeah. So MRI, again, though the equipment is larger, the cost of the equipment is higher. Yeah, I'll continue. So this basically contains device. So it contains a device where it contains a magnet other side which receives the radio waves. So what is the mechanism exactly? Is a magnetic field is applied. So this allows the protons in the okay. So the principle of this MRI is, so when you see in the normally the proton are not in alignment. So when we apply magnetic field, the protons get aligned up. So when along with the magnetic field, if you send a radio waves, this again the protons which are aligned are out of proportion. So the time it is taking back to get aligned under the magnetic field is analyzed by the receiving coil, that is a radio wave antenna that is present on either side. This takes up the information and image is constructed. So as the nuclei align back to into proper position, they send out radio signals that are captured by the radio antenna, and this is measured by the computer system and analyzed and converts them into an image of the part being explored. So disadvantage of MRI is it's a longer scanning time and strong magnetic field is generated, and also there are artifacts that or interferences that has happened when a metal object is present in the field of observation. So this is an again indice differentiation that is done based on the MRI, and there are the different criteria like the outer margin. You can see in the upper part of the diagram where the upper part is a cyst, the lower part of the picture is the granuloma. So they analyze 5 criteria, that is the lesion center, peripheral rim, outer margin of the lesion, involvement of the surrounding tissue, and thickness of the peripheral rim. So the peripheral rim is thicker in granuloma, thinner in case of cyst. The texture of the peripheral rim is homogeneous in the cyst, inhomogeneous in the granuloma, and lesion center, whereas in cyst is homogeneous, non-homogeneous in case of granuloma. So we can easily differentiate which whether it's a cyst or a granuloma. So again, though it is only a research part, we have also used molecular-based diagnostic strategies to differentiate vital and non-vital pulp or pulpitis case. So when a pulpal inflammation happens, it's always microscopic and at the molecular level. Your interferon gamma, interleukin 1, there is a cell-mediated inflammation. These cytokines can be analyzed by use of radioimmunoassay, RT-PCR for gene expression, ELISA, double diffusion is in agar, or immunohistochemistry. So either of it can be used to analyze the cytokines. So how do you get the cytokines? We can use for a dentinal fluid sampling or pulpal blood. So pulpal blood is not possible because we need to extract the tooth and analyze the pulpal blood. But more convenient is to use the dentin fluid by means of absorbent cotton that's placed, and we can analyze the fluid for presence of any cytokines. So when we have a pulpitis, there is an increase in the expression of MMPs, tumor necrosis factor, advanced glycation end products, all will be at a higher level in irreversible pulpitis compared to the normal pulp. So American Association of Endodontics have given newer diagnostic terminologies. I request all of you to go through this article or in the newer edition of the Ingle, where he has given entire list of the terminologies that has been used. So pulp necrobiosis also has been added, where part of the pulp is necrotic and the rest is irreversibly inflamed. So it's more appropriate to use is symptomatic and asymptomatic pulpitis rather than reversible, irreversible, which is mainly histological. And the difference between, so once we have completed now the part of the presentation where different tests, different radiographic method can be utilized. Now we'll go for individual conditions. So how do you differentiate between reversible and irreversible? That's main depend on the pain type. So reversible pulpitis is a momentary pain which ceases soon after the removal stimulus. Removal of stimulus is done, whereas irreversible pulpitis is always intense, prolonged, and sometimes referred pains will be there because this is where the C fiber gets activated, which is present in the central part of the pulp. If at all referred or patient is not able to localize the pain, that means that the reversible pulpitis has happened. And pain localization is always possible with reversible, but irreversible it is not possible. And exaggerated response, though for only the time it is placed, is visible in reversible pulpitis. Irreversible pulpitis normal to elevated. Sometimes pain relieved by cold, and it's always an acute pain. And sometimes if the PDL is involved, the percussion test is positive in irreversible pulpitis. This is how we can differentiate. It's mainly by the pain type, which we can differentiate between reversible and irreversible pulpitis. And we can also use pulp vitality, pulp test, sensibility test, where carbon dioxide or dry stick is more appropriate compared to the EPT. If at all we have a pulp canal calcification, EPT is more reliable compared to the dry ice. So we can see here in this picture, in this table, there are different authors who has used pulpitis in a different way. So we need to have a terminology which is most commonly used, and this process is still happening. So any other diagnostic sorry, I think so this is a part again, this is a slide where we can how to diagnose granuloma and a cyst. So we have, these are the available methods: periapical radiography, CBCT, MRI, and ultrasonography. So periapical radiography mainly was diagnosed in the terms of lesion size and the outer rim. There is a outer rim of a cyst. On that basis, it was diagnosed, but both are unreliable and not matching with that of the histological criteria. And next, they started using intraoral digital radiography and texture analysis of the content or the central part of the lesion. Based on the grayscale values, we can actually differentiate between a cyst and a granuloma. And they started using CBCT, where they can use a lesion size or the volume of the lesion to analyze the periapical lesion between granuloma and the size. And also we can use in the CBCT texture parameters to characterize the lesion. So these are the texture parameter which they have used to come to a differentiation. So now coming to the Craze line is most often in the enamel, which we can see most often in the, but we can clearly see in the anterior region. Fractured cusp, cracked tooth, vertical root, or split tooth, all depending on the extent. We also have fracture necrosis, where there is no visible evidence of any restoration or a caries, but there is a pulp non-vitality. So we can give the term as a fracture necrosis. So vertical root fracture, we can diagnose main on the three part. There is a deep osseous defect, narrow probing, especially on the buccal or the side where the fracture has happened. A sinus tract is present higher in the part of the gingiva as opposed to periapical lesion. A J-shaped radiolucency or a halo appearance, which is a combined periapical and perilateral radiolucency. We can use these three along with the CBCT to diagnose a vertical root fracture. And horizontal root fracture, there are different guidelines provided by different bodies. As per the dental traumatology guideline, International Association, they tell we need to take a 90-degree horizontal angle radiograph along with the occlusal view and periapical radiograph with different angulation. We call it as traumatic radiograph views. So also along with that, we can use a CBCT imaging to visualize the dental injuries, especially the luxation injuries, and to monitor the, not that of use, we need to use So I think I was near vitality test for traumatized teeth. How do you start with vitality testing for a traumatized teeth? So most of the times, freshly traumatized teeth, they are inconclusive for the pulp sensibility test. This is because of neuronal degeneration. There is loss of the myelin sheath and swelling of the axonal. So this is only transient. So again, waiting period of 15 days to a month, there is region, the myelin sheath will be, whatever the loss will be regained, and we can do a pulse sensitivity test. More appropriate for this newly traumatized teeth are the one which measures the pulpal blood flow, that is pulse oximetry, laser Doppler flowmetry, or ultrasound Doppler flowmetry. So though they are technique sensitive, they are very good in assessing the pulpal vasculature. When we have a transverse root fracture, we can classify as an apical third, middle third, coronal third. Again, coronal third can be subcrystal and supracrystal. So transverse root fracture always comes with increased mobility or displacement of the coronal fragment. There will be tenderness to the percussion. There will be discoloration transient. Either it can be red, or it can be, if the patient has come after a long period of time, there will be a grayish discoloration, bleeding from gingival sulcus. Teeth with root fracture, there may be minor displacement of the root also, and we need to take trauma series of radiographs, that is the periapical, eccentric, and occlusal, which provides a valid cue for the diagnosis and transfer root fracture. So when a patient comes with a traumatized dentition, first we need to take a Glasgow Coma scale to analyze the verbal and the motor response of the patient. We need to analyze whether there is any potential jaw fracture. So once we have ruled out both, then we can ask regarding the injury, where, how, and when it happened. And we also need to know whether the injury is because of a immovable object or a movable object, because the intensity and the pattern of injury also matters. And we need to have a photographs. That is more important for the medical legal issues. And we need to observe the soft tissue injury. And we also need to know the occlusion, whether there is any change because of the traumatic dental injury. Once we have analyzed this, we need to analyze the teeth particular, whether there is any exposure of the pulp or there is any fracture of the crown. If there is any missing fragment is there, we need to check in the lip or the cheek, which has been embedded. We also need to do the pulp vitality, that is the vascular supply over a period of time, to know whether there is a vasculature supply is maintained. And we need to take at a radiograph at a different angulation and a CBCT if required. So this is how you manage from patient who comes with a traumatic injury. As this is a traumatic injury form which has to be filled and entered, and also to be filled during a routine follow-up. Cracked tooth syndrome. So this is again one of the most important part which always comes with the diagnostic dilemma. We need to do translumination and most importantly clinical symptoms. And I already have told what are the types of longitudinal fracture the tooth comes with. There are 5 longitudinal fracture. So the crack is there. We need to go for translumination, bite testing, methylene blue staining, tracking with the with the burr, and pulp vitality and radiographic assessment. All those has to be done. And we need to reproduce the pain by use of a fact finder or a tooth sleuth. We need to keep it on the patient tooth and check for the reproducing the pain. So you can use crack visualization after removal of the filling. We can use with the transillumination. We can use a methylene blue staining. And when this is the American Association of Endodontics exam, where they have told that these are the procedures that is required to make an endodontic diagnosis. we can have a chief complaint, which includes the symptoms, duration, onset, location, and any medication that is taken. Clinical examination has to be done with the pulp testing, radiographic analysis, and the additional tests. These are the required by the American Association of Endodontics guidelines to make an endodontic diagnosis. And these are the comprehensive clinical diagnostic system where we can tell which part, like either pulpitis or your periapical disease criteria. And when we come with the diagnosis, we can have a provisional diagnosis at the time of history taking, again at the time of clinical examination, again at the time of clinical test, radiographic examination, and the definitive diagnosis should be given after correlating all the examination that has been done previously. And accordingly, we can provide a treatment plan. Recently, they have used electrodermal activity along with core testing. So there is a sympathetic activity that has been measured by use of electrodermal equipment. So this enhances the sensitivity of the cold and EPD testing. So this completes my presentation, and I thank Krishna Prasad sir and Nagesh sir for providing me opportunity to present to all of you. Any question is there, I'll be taking. Thank you. So I went fast. I think I wanted to take some questions. Any question is there?
Yes, sir.
Rupa?
Yes, sir. Thank you so much, sir. That was the finest and insightful presentation. It was very informative, sir. We appreciate you for your time and effort, sir.
I think I went fast. I went faster. I thought I will not be able to complete, but I think I completed.
Sir, 20 minutes time is there, sir. You have provided very easy to use the comprehensive guidance, which will certainly
Any questions?
help our participants to deal with endodontic diagnosis, sir. Sir, one of the participant has posted a question in the chat box.
Yeah.
Dr. Y. Prashant is asking that should we follow AE guidelines 2020 for diagnosis of pulp and periapical tissues, or any new guidelines are developed recently?
So we need to go through the terminology itself, because where he has recently classified pulpal as well as periapical nomenclatures. So this is the recent what we need to go through as per that nomenclature. I think that is what the answer expected. Rupa, the question was actually
Yes, sir.
some disturbance was there.
Yes, sir. Should we follow American Association of Endodontics guidelines 2020 for diagnosis of pulp and periapical tissues?
Yeah.
Or any new guidelines are developed recently?
That is the guideline what is given in the 7th edition also.
Yes, sir.
Ingle 7th edition. So we'll follow that only.
Participants, any questions from your side will be answered by Srinidhi, sir. You can post in the chat box.
So they can send me, I can send you and I can get back to them through mail if at all any doubt is there.
Yes, sir.
So I think one more question has come. Okay, which good book? Preeti madam knows more than me, I think. Okay. So what I have, I have already shown in the PPT also. So for every diagnostic test, there is an article which from the JOE or IJ. I think that articles is much better, and that is covers the entire part of each test. And also the Ingle provides elaborate information of all the tests and also radiographic interpretation, which I have not covered in this slide. Radiographic interpretation is very well covered in the Ingle. I request all the post students to go through the Ingle ones. And by Patel, there is again one more diagnostic book, endodontic diagnosis. He has covered entire problem that may come across in endodontics. So that also can be referred. Rupa, any more question?
So no more
So
questions.
in geriatric patient, how's sclerotic dentin? See, that's what is the, yeah. Okay. So this I have already mentioned in my slide. So cold test is not very reliable. So if, sometimes even test cavity is also not reliable. So we need to rely more on the patient symptoms and radiographic analysis. So as I told in my presentation, EPT to certain extent may be reliable in a patient who is having calcified root canals. In a tooth which is having crown, yeah, you can go with the green ice. So again, this is not possible. You can open up you can place a probe. If at all is the superingeal margin of the crown is visible, you can keep a probe and then provide the either electric pulp testing. And again, care should be taken not to provide a false positive by contacting with the gingiva. Can MRI be used in patient with implants? Again, there's an artifact. Again, they sell the diagnostic information. What we get will be very minimal when we use an MRI. So the diagnostic accuracy will not be obtained. And if at all implant is in the same place as that of your area of interest, we will not be able to get any information. So that's again contraindication to be used. Clinical test where cracked tooth syndrome and fracture. Bite test is more appropriate. Fracture, which fracture you're telling? A split tooth, cusp fracture. Split tooth you can readily see. There is a complete separation of the fragment. Okay, cracked tooth syndrome is mainly we need to reproduce the symptoms. So by use of a frag finder or the tooth sleuth, we need to reproduce. So that's what split tooth or vertical tooth fracture. This is very evident, right? Vertical tooth fracture or split tooth is readily visible. So we can easily differentiate. There is a complete separation of the fragment. So what is required is only crease line and crack. So that can be differentiated between on the symptoms. So crease lines is mostly asymptomatic. Rupa, have I answered? You are able to listen to the answers what I've...
Yes, sir. We're able to listen, sir.
Yeah. So we'll wait for another 15 minutes. Okay. If the fracture is not visible clinically, do a dye testing. Methylene blue apply on the fractured tooth. It will stain the organic matter that is present in the fracture line. You'll be able to visualize. You can do your curing light is there, right? We are doing in our clinic. So your curing light, if at all it is high intensity light, you can pass it onto the tooth. You can visualize if at all evident crack is there. So what we follow in our call department is methylene blue staining and as well as transillumination and the bite test. Reproduce the symptom of the patient.
So Dr. Vipin is asking how to differentiate between transient root resorption and external or internal root resorption.
Transient root resorption and
external or internal root resorption.
Transient root resorption is only visible in the CBCT. As such, very minimal resorption will not be visualized in a normal conventional radiography. Internal and external, that is what I have missed in my presentation. It would have been better if it have included a differentiation between external and internal. It's basically, we can use a different angulation X-ray and the involvement of the canal in the internal resorption, ballooning of the canal in the internal resorption. If at all it's perforated, again, the total of entry exit is very smaller compared to your external resorption. Which is, test is more practicable. You can use endofrost, that's easily available, right? And there's more reliable, more accurate for using chairside pulp vitality test. So this is what is artifact. So we should not rely on CBCT. We need to rely on other diagnostic tool. So this is what is being taught to everybody. Never go with one test. Always always do 2 or 3 information that has to point towards a particular defect. Then only you go with the treatment. See, I showed you a radiograph where there was radiolucency of the 3 teeth. So what actually one does, okay, we have 3 teeth and it's a traumatic injury, we'll go with the acid of the 3 teeth. So we need to confirm not only the one, at least 2 or 3 tests which should point out what defect it is, what diagnosis we need to come across. There's an artifact in the CBCT, or the plane which you have visualized is a wrong interpretation. Or the resolution is not sufficient enough to diagnose the horizontal fracture. That's all non-vital teeth. Then what you are going to do with the, if it all is, see, a non-vital tooth, yeah. You may not require when there is a pulpal obliteration. Again, pulpal obliteration, we can't tell it as a non-vital tooth unless all non-vital tooth require us. That is the answer. Yes. Rupa, any more questions?
Yes, sir. As we are crossing the time, sir, they will post their questions or queries to our endodontics at the rate of 6.ac.in. We will forward to you, sir.
Definitely.
Yes, sir. Sir, thanks for your patient answering to the questions asked by the participants, sir.
Pardon me? Rupa.
Sir, Dr. Sunil, sir. Sir, as today's presentation, which is being recorded with your consent, may be used for educational purpose in future at Sibar Institute of Dental Sciences, sir. Now, we hand over the certificate of appreciation as a token of gratitude to our beloved speaker, Dr. Srinidhi, sir.
Thank you. I hope the presentation was properly covered and was audible to all the participants there. Maybe hurried up, I think. Yeah. Thanks, Balgopal sir. Thanks,
Thank
sir.
you, Srinidhi.
Are we audible?
Yeah, you are audible. Sunil can continue.
Thank you, Dr. Srinidhi, for a really wonderful insight into the diagnostic aspects of endodontics. And, thank you for the detailed explanation of all the queries. Further queries, as Dr. Rupa has mentioned, that it will be forwarded to you. Once again, thank you very much for your unconditional participation.
Thank you. Thank you very much.
We would like to thank all our speakers who have joined us today for this session, especially Dr. Amardeep ma'am, Dr. Ramsunil sir, Dr. Murli sir, Dr. Balagopal sir, Dr. Satish Alapati sir, Dr. Siddeshwaran sir, Dr. Mohan Thomas sir, Dr. Mounta Kaushik madam, Dr. Prashant sir, Dr. Ramya Raghu madam, and Dr. Ashish Shetty sir. All the registered participants, please fill the feedback form which is posted in the chat box to receive the certificate of attendance. Next topic of presentation is by our expert speaker, Dr. Amandeep Kaur ma'am, on the topic traumatic dental injuries on 4th February from 5 to 7 p.m. Thanks to all the participants for your patient listening and attention.
Thank you, all of you. So we can log out, right?
Yes, sir. We can.
meeting ಕೊಟ್ಟೆ ಅದೇ stop.
Shilpa ma'am, anyone from A1 Logics? Dr. Sunil sir wants to have a mock trial. Can we do for 2 minutes?
Yes, ma'am.
Participants, you can leave the meeting. Thank you.
Ma'am, Rupa ma'am.
Yes, ma'am.
I'll stop the YouTube live, okay?
Yeah, you can stop, ma'am. You can stop.
Yeah. 1 second, I'll stop the share screen.